Di sini ada 1663 DOL 16 itu Prof Najib ya, Dok?
Betul ya?
Saya admit ya, Dok?
Iya, betul-betul. Nanti kita admit sebentar ya, Prof.
Ya.
Ya, makasih, Prof.
Sudah di-admit ya, Dok?
Oke, berarti lengkap ya. Moderator ada, Bu Vivi sudah, Pak Didi sudah, Prof Najib, itu dia, Prof. Oke ya. Sudah lengkap tadi kita, Prof?
Ya.
Assalamualaikum, Prof. Terima kasih.
Waalaikumsalam. Saya ganti dulu nama saya nih, emang ngaco nih. Ini udah ada izin masuk rupanya ya.
Iya, Prof. Maaf, soalnya ini udah pada mau masuk, kita pilih-pilih dulu, Prof. Maaf.
Bentar ya.
Dokter Windas, sudah jam 8, mau persiapan buka, jam 8:01. Ya,
jingle, kita buka acara semuanya, bismillahirrahmanirrahim. Panitia siap-siap, silakan jinglenya dulu dibunyikan ya.
Kerja dulu ya.
Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda. Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda.
Hello everyone. Assalamualaikum warahmatullahi wabarakatuh. Good evening to all participants. I'm Winda Azwani. I will be your host for this guest lecture for around 2 hours. I would like to say thanks to all speakers, moderator, and also our colleague and our friend, our professors, and our nurses maybe, and all the students that virtually we can meet tonight. We will have a guest lecture with the speaker is Dr. Regan Giesinger. She is a neonatologist from University of Iowa State Family Children's Hospital. But she's not here yet, but we will open this event until she will join us. Okay, I will let our CEO, Dr. Vivianti Azwar Mars to open this guest lecture. Kepada Ibu Vivi, saya persilahkan.
Terima kasih Dr. Winda. Assalamualaikum warahmatullahi wabarakatuh. Saya ucapkan selamat datang kepada seluruh partisipan pada acara guest lecture RSAB Harapan Kita. Terima kasih kepada pembicara Dr. Regan Giesinger dari IOA Amerika Serikat, dan juga terima kasih kepada moderator Profesor Najib Afani, konsultan kardiologi anak dari Rumah Sakit Cipto Mangunkusumo. Kali ini kita akan mendengarkan tema yang sangat menarik, yaitu hemodinamik kardiovaskular pada neonatus yang berkaitan dengan hipoksia iskemik, ensefalopati, dan akibatnya terhadap otak. RSAB Harapan Kita sebagai pusat kesehatan ibu dan anak adalah rumah sakit rujukan nasional, termasuk untuk kasus neonatal. Kami terus meningkatkan ilmu, kemampuan, keterampilan, dan jalinan kerjasama untuk menangani kasus neonatus. Selamat menikmati acara kuliah tamu RSAB kali ini. Semoga bermanfaat bagi kita semua. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for your opening speech, Dr. Vivi. And we will proceed to Dr. Didi Danukusumo. He will give a keynote speech to this evening lecture. He is the Director of Birth Defect Integrated Center from RSAB Harapan Kita. Dr. Didi Danukusumo, he is a fetal maternal consultant, obtained his medical doctor in 1986 and specialist in obstetric gynecology in 1994. After that, he obtained his consultant in MFM in 2007 and the PhD in 2016, all from the same university at Faculty of Medicine, Universitas Indonesia. He also obtained a Master of Public Health from Gajah Mada University. Additional education in reproductive health sciences in Sweden in 2000 and in Switzerland in 2003. Work as a health center doctor in Southeast Sulawesi, eastern part of Indonesia, and also after that he started his career as obstetrician and gynecologist at Kuala Tunggal Hospital. Of course, Pak Didi is have several experience as a director and from Fatmawati General Hospital, and after that he moved to our hospital and until 2021. Currently as head of Birth Defect Integrated Center at Harapan Kita National Center for Women and Child Health. Pak Didi, the time is yours.
Okay, thank you very much, Dr. Winda. Dear our distinguished guest, I hope that she already joined us, Professor Regan Giesinger, Madam CEO, Dr. Vivianti Azwar, Professor Najib Afani as moderator from University of Indonesia, Dr. Johannes Edi Suswanto as a panelist from our hospital, and to our participants. Good evening to us at Jakarta and good morning for Professor Giesinger at Iowa. Assalamualaikum warahmatullahi wabarakatuh. You know, fetal neonatal adaptation is a crucial period. Fetal cardiovascular adaptation to hypoxia and ischemia initial insult of the newborn, such as ongoing hypoxia and cardiovascular instability, will cause instability cerebral perfusion and lead to brain injury. Data 40% death of neonatal HIE, the rest will have neurological sequelae. Why right ventricle? Right ventricle is vulnerable in neonatal period, resulting cardiovascular hemodynamic instability. Needs to perform echocardiography for high-risk neonates, including with hypoxia, ischemic encephalopathy. In conclusion, cardiovascular manipulation as a window opportunity to successfully treat neonatal with HIE. Birth defect, congenital heart defect is number one birth defect in RSAB harapan kita. Neonatal with CHD needs particular management regarding cardiopulmonary adaptation. The role of echocardiography will help to determine the pharmacological, surgical, or intervention. Collaboration between fetal-maternal specialists, neonatologists, and pediatric cardiologists will decrease neonatal morbidity and mortality. And we hope that we can gain our knowledge by joining the guest lecture from Professor Giesinger and will improve our practice for our patients. Dr. Winda, I give back to you the time. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Pak Didi, for your keynote speech. After this, we will start our scientific session. We still wait for Dr. Regan Giesinger. She will join us, I think, in another 10 minutes. Before that, I will explain about the housekeeping for our guest lecture this evening. The committee, please show the slide. Okay, please make sure that you turn off your sound and video during the session. And also please fill in the attendance form because we will give you the e-certificate 2 weeks after this event. If you have any questions, please type your question on the chat room. Okay. After this, we will open the scientific session. Our moderator this evening is Professor Najib Advani. We will have his curriculum vitae. Prof. Najib Advani is a consultant of pediatric cardiologist. He completed his pediatric residency at University of Indonesia and cardiology fellow at Sophia Children's Hospital, Rotterdam, Netherlands in 1989, and also at Royal Children's Hospital, Melbourne, Australia in 1998. He's also an expert in Kawasaki. He obtained a consultant in pediatric cardiology in 2005 and also attend several symposium about Kawasaki, including at San Diego in the United States. And also Prof. Najib has obtained his Master of Medicine in Pediatrics at the University of Melbourne, Australia. He has a lot of experience as head of UKK Cardiology, Pediatric Cardiology Working Group, treasurer and consultant of Yayasan Jantung Anak Indonesia, and also Indonesian Cerebral Vascular Society. He's also a member of Indonesian Doctor Association. And actually, Prof. Najib is our expert in Kawasaki disease in Indonesia. Okay, Prof. Najib, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Winda. Dr. Didi and Dr. Gigi Vivi for introducing me and allow me to be a moderator to that today. Welcome to all of the attendees. It is really a pleasure for me to have you all attendees here in this evening. I'm delighted to introduce to you Dr. Regan Geisinger, who is one of the leaders in the field of hemodynamics of critically ill neonates and the relationship between cardiovascular functions. And we can see from the topics he is going to present today. Perhaps it is rather new for some of us, and this topic is rather new for us. So now let me read her CV first. Dr. Regan Geisinger is an associate professor in neonatology and director of neonatal hemodynamics fellowship program. Is medical director in neonatal transport. Her education is BSGS in biomedical science of Gulf, Ontario. MD in medicine, Queen's University, Kingston, Ontario, Canada, and pediatrics residency at University of Western Ontario, London, Ontario, Canada. Clinical fellow, neonatal perinatal medicine, University of Toronto, and clinical fellow, targeted neonatal echocardiography program, University of Toronto, Ontario, Canada. Her interest her areas of academic focus are the hemodynamics of critically ill neonates and the relationship between cardiovascular neuro outcome, particularly among neonates with neonatal ataxic ischemia problems. Okay, so let us hear from her. I welcome Dr. Regan Geisinger to give you a lecture.
I think we still wait for her, Prof. Majid.
Okay, no problem. I think for many of us, the function of right ventricle function and the relationship between right ventricle function, the outcome of neonates with HIE is still quite new, yeah. And her research mostly about the RV function in that relation with the outcome of the neonates with HIE. It seems, how is it? We don't. Let us listen to her. It's quite interesting, I think, you know. But it is maybe rather new for us. Whether it is applicable or not for us, we'll have a look later. Okay? Hopefully, this lecture would be very beneficial for all of us, especially in making progress in our service to the neonates in Indonesia. So we can wait for her. Maybe there's some problem. Yes, we are still waiting for Dr. Geisinger. There are already 120 attendees in this session. I hope the number will increase and will be beneficial for all of us. Yeah. especially the neonatologists, pediatric cardiologists, and pediatrician who are interested in this matter. Any news from her, Dr. Winda?
Yes, I sent email, Prof. Please take a couple of minutes.
Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda. Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani dan anak negeri, rumah sakit harapan kita, pusat kesehatan anak dan bunda. Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda. Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda. Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda. Indonesia tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda.
Hello. I have a reply from Dr. Regan. She has a patient issue. She will be here shortly. Don't worry. Hi, Regan.
Sorry about that.
Hi, thank you so much, Regan, for your accepting our invitation. We have, I think, around 140 participants this evening. Good morning, Regan. I'm Winda. I'm pediatric cardiologist at Harapan Kita National Women and Children's Hospital. We have opened this event. Thank you so much. And we have a moderator, is our teacher, Prof. Najib Advani. He is also a consultant of pediatric cardiologist, but we also have a consultant of neonatologist, don't worry. Okay, Prof. Najib, please, time is yours.
Okay, thank you, Dr. Winda. Good morning, Dr. Regan Geisinger. Is it right, Geisinger or Geisinger?
Yep, that's good.
Okay. We have just showed your curriculum vitae, and we are very eager to know your presentation. I think it would be very interesting for all of us. So I welcome Dr. Geisinger. Please, time is yours.
All right, I will just share my screen and put on my presentation here for you. All right, and do you see my first slide?
Yes, all right. It's very clear.
Okay, perfect. So thank you very much for the invitation to come and speak to you this morning for me, evening for you. I'm going to talk a little bit about the HIE therapeutic hypothermia population and how the cardiovascular system may play into illness severity. I have nothing to disclose. So first of all, just so that we're all brought up on the same page, HIE is the terminology that's used to describe the brain injury which results from when fetal compensatory mechanisms to impaired cerebral blood flow fail. This leads to cellular energy failure, results in excitatory neurotransmitter release, and also increases the production of reactive oxygen and nitrogen species, which lead to electrolyte dysregulation. And all of this taken together stimulates the production of inflammatory mediators, which then go on to create a secondary phase of injury in which cellular apoptosis occurs. Therapeutic hypothermia is one of the best studied interventions in neonatology. Between 1998 and 2010, 7 trials randomized over 1,200 neonates with moderate to severe HIE to therapeutic hypothermia or normothermia. And the composite of death or major disability favored cooling, with a number needed to treat of 11 for mortality and a number needed to treat of 8 for a lower burden of neurodevelopmental impairment in survivors. So the mechanism of neuroprotection is actually complex and multifactorial. reduction in brain metabolism leading to lower oxygen utilization, modulation of cerebral blood flow, and reduction in edema and inflammation are among the most common mechanisms described, but there are probably other contributors as well. And despite this, about 40% of neonates either die or have severe neurocognitive sequelae following HIE. And in 2022, that's still a pretty big number. So as previously mentioned, there are two primary mechanisms of brain injury for these patients. There's necrotic cell death from the initial injury, and then there's secondary energy failure. The prevention of secondary energy failure is actually the place where therapeutic hypothermia is thought to play its role. And all sorts of other adjuvant therapies are being investigated to try to heighten the effectiveness of cooling and maximize the benefit for neuroprotection. One thing that we often don't consider, though, is that hypoxia ischemia, which is a sentinel part of the original injury, is often not a single time point effect. Ongoing impaired cerebral blood flow and hypoxemia after the initial insult, which might be due to inadequate cardiovascular stabilization in the setting of impaired cerebral autoregulation, may actually contribute to ongoing development of necrotic cell death and ongoing cells going into the apoptotic phase. So in pre-cooling studies, the pattern of brain blood flow in several major arteries has been studied and shown to be associated with adverse outcome. Either low resistive index due to high diastolic flow or high resistive index due to absent diastolic flow are more prevalent among patients with more severe injury in a variety of blood vessels in the brain. And in comparison to other organs over time, patients with more severe disease display a different pattern of blood flow over the first 72 hours than other vessels in the body. And here you can see a graph where the dark bars represent the blood flow to the brain in babies with more severe HIE, on the left to the middle cerebral artery, and then on the right, liver and bowel flow in the celiac artery. And you can see that in the more severely affected patients, cerebral flow is actually augmented over the course of the first 72 hours, where that doesn't happen in celiac or other arteries in the body. Importantly, though, to understand the mechanism, we have to actually have simultaneous evaluation of systemic hemodynamics. And none of the three studies that I've just mentioned present any data on heart function or cardiac output. So the contrary is also true. This is a small cohort study which was published in 2014, and it demonstrates that patients with abnormal brain MRI at 72 hours had 70% of their cardiac output directed towards the preductal circulation, as compared to 50% amongst patients with a normal brain MRI. But at the same time, this this study doesn't have any data on cerebral blood flow. But in combination with the cerebral Dopplers, the other studies that I presented, this suggests that hyperperfusion may be associated with adverse outcomes. Another way to look at this question is using NIRS, which is a non-invasive method of measuring regional tissue oxygen extraction or oxygenation. It primarily affects the venous compartment, and it's therefore a measure of oxygen utilization or extraction by the organ. And if you have high regional oxygenation, it reflects low extraction, or can reflect low extraction, which can be seen in the setting of high cerebral blood flow. Multiple studies, including a large systematic review of about 50 studies using NIRS in this patient population, support the fact that high regional RSO2 is a prognostic marker for poor outcome. The graph on the right shows various different markers of illness severity, and shows that in this comparator cohort, much more patients who had an adverse outcome had low variability in their RSO2 as compared to patients who had better outcome. And this suggests that not only high cerebral RSO2, but also low variability would be associated with adverse neurological status. So if cerebral blood flow is different, then it's plausible that the cardiovascular system holds a key to modulating disease. We know that cardiovascular disease is common. We also have very little literature supporting one therapeutic approach over another, which leads me to speculate that everybody is doing something different. And that gives us an opportunity to evaluate which approach is best and harmonize our care. So if we accept the premise that cerebral blood flow and oxygenation are modifiable contributors to disease, it becomes essential then for us to understand the factors that modulate cerebral hemodynamics. The initial insult, hypothermia, and rewarming all contribute to changes in cardiac output, changes in loading conditions, and changes in both pulmonary and systemic vascular tone. And all of these things may contribute to either ischemia or reperfusion injury at various different time points across the period of cooling and rewarming. This is just a reminder for those who may not have read this for a while. The fetus actually, in their adaptation to hypoxia ischemia, this is important for understanding how they manifest postnatally. The fetus initially adapts by centralizing all of their blood flow to the brain, the heart, and the adrenals. They do that by having a catecholamine surge, which basically vasoconstricts all the other organs, including the lung. And pulmonary vasoconstriction as a result of this is a compensatory mechanism, but also it differs. About 10% of the blood flow that was previously going to the lung, and particularly this is important in adapting to neonatal life, that pulmonary blood flow goes from 10% down even lower, and then the right atrium gets under higher pressure, which diverts more flow across the PFO in order to perfuse the brain and the coronaries. So just keeping this in the back of one's mind as we think about how babies adapt postnatally. And in addition to this being born with higher pulmonary vascular resistance than what a normal fetus would expect to be, temperature alone is an important modulator of pulmonary vascular tone. And so this is a term patient who had a hemodynamics consult prior to cooling. And the baby had severe metabolic and lactic acidosis and had an oxygen requirement of about 40%. And then they had a clear chest x-ray. So the clinical team was concerned about pulmonary pressures. On our initial evaluation, which you can see kind of a ductal cut or a modified ductal cut on the left with the red flow left to right through the PDA, you can see that she had kind of near systemic pulmonary pressures, but with mostly left to right ductal flow. Her target temperature was then lowered over the course of about 30 minutes. And by the time she reached 33.1, her vital signs are below the echo images there. And you can see her FiO2 went up from 40%, 50%, 75% to 100%. And her blood pressure was pretty much the same at the start, 56 systolic, 54 systolic, at the start and end of this cooling period. And so the fact that this similar ductal cut shows a PDA with almost all right to left shunt must mean that her pulmonary pressure has gone up. And this is because for every 1 to 2%, or for every 1 degree drop in temperature, you get a 1 to 2% increase in pulmonary vascular resistance, and means that we just need to be careful that cooling remains a post-resuscitation intervention. The other thing that's important to know about this population is that clinical research in this physiology is very challenging. We start off with a baby who has already many established markers of poor perfusion because of the initial insult. And then the tools that we have to evaluate the baby are pretty simple and are unable to distinguish between new and ongoing things versus historical things a lot of the time. And even abnormal blood pressure, which sounds like it's a pretty simple concept, is something that we don't necessarily agree on. So this is a survey that we conducted a couple of years ago in North America, where we asked 71 academic centers about their definition of low blood pressure in this population. And what we found was that there were 17 operational definitions of hypotension being used actively at that time. And that's important for a lot of reasons, but one of the most relevant to me reasons is that it's really difficult to do meaningful research if we don't all agree, even on treatment thresholds, even on treatment thresholds. One of the other important things is that many of our markers of ongoing impaired tissue perfusion are actually difficult to use also. So on the left here, you see a receiver operator characteristic curve for base deficit and lactate to predict the severity of the initial insult. And you get a pretty high ROC, suggesting that both of those, metabolic acidosis and lactate, are more likely to predict the severity of the initial insult than of ongoing hemodynamic instability. And then the graph on the right is cardiac output versus rate of clearance of lactate. And you can see there's basically no relationship between what the cardiac output is at the time and how fast the lactate clears. And in fact, in that study, the clearance was also more related to the severity of the primary insult than of ongoing cardiovascular instability. The other thing that's important to know is that that therapeutic hypothermia itself modifies pre-existing acute kidney injury. And so we know that acute kidney injury is common, about 70% incidence. We also know that it's severe in about 30% of those patients. And so already it's difficult to rely on urine output as we normally would. But then in a very interesting study done in adults were cooled for unrelated etiology to the kidney. And what was found was for every degree reduction in temperature, the cooling alone generated a reduction in urinary output. And that's really important to keep in mind, especially when we're thinking about drug clearance, which I'll talk about in a minute. So in US centers, and this may not be applicable in over in your practices, but in US centers, a good proportion, 40% of institutions do not actually routinely request echo, even if a patient is requiring vasoactive support. And things like ejection fraction, which is a quantitative assessment of LV performance, is frequently reported, but only qualitative assessment of RV function is reported in a majority of centers, and most places do not report cardiac output. We do know, however, that if people do echo, we have reliable data to suggest that echocardiography can identify dysfunction in these patients, and that's both by conventional measures like shortening fraction and cardiac output, and more sophisticated measures like peak longitudinal strain, which are different in asphyxiated infants versus healthy term controls, regardless of whether they're cooled or not. But there's never been any association identified between LV dysfunction and neurologic outcomes. So this brings me to kind of my research and the role of the RV. So this was a baby that I'm never going to forget because I thought I had diagnosed hypoplastic left heart on my 4th day as a hemodynamics fellow. So she was a baby who I was asked to scan because of isolated low systolic blood pressure. And otherwise she was clinically fairly in keeping with what you would normally get. This was, of course, on a Saturday evening, and my supervisor was at soccer. So I was kind of panicking that I wasn't going to have anybody to review this with. And this baby, this is for those who aren't familiar with echo, this is an apical 4-chamber picture. The structures on the left of the image are the right-sided heart structures with the atria at the top. And the structures on the left side, or sorry, on the right side are the left heart structures with the atria on the top. And you can see that this right ventricle is, even with the naked eye, giant compared to the LV, and that its function is poor. So this led us to speculate, why might the RV in particular be impacted in patients who have more severe injury? And some of the speculations were that, and some of the studies suggest that the right ventricle is actually more vulnerable. And that's for a couple of reasons. One, because it has a higher metabolism and requirement for blood in the transitional circulation because of its much more prominent role in fetal life and in transition. It also has a high ratio of circumferential radius to wall thickness, which means that the conformation in that it's wrapped around the LV is more vulnerable to wall stress for equal afterload as compared to the left ventricle, and because the myocytes are more spread out, and if they get stretched, they get even more spread out. And it also has more vulnerable coronary flow, and this is because the flow to the myocardium is primarily dependent on a gradient between the aortic root and a mix of the central venous pressure and the cavity pressure of the RV. And the aortic root pressure is commonly low in these patients because they have low cardiac output, because they have low blood flow through the lung. And at the same time, because they often have pulmonary hypertension from failing to adapt to postnatal life, the RV cavity pressure is usually high and the central venous pressure is usually high. So the gradient to flow between what is normally a high aortic root pressure and a low cavity and central venous pressure in the RV gets obliterated. And then thinking about kind of why this association potentially hadn't been identified until we started looking into it specifically. One of the reasons for that is because, as I mentioned previously, most places are not looking quantitatively at the function of the right ventricle, and subjective evaluation, particularly for mild to moderate dysfunction, is not very reliable. And this has been shown in adult studies, in pediatric studies, and this is a neonatal study showing very poor kappa coefficients between readers. That in looking at 3 common measures of RV performance, 1 is the RV working well, 2 is the septum flat, and 3 is the RV dilated. And you can see that all the kappa coefficients are basically less than 0.2. And relatively recently, we had normative data for neonates in day 1 and 2 published. And so hopefully people will start to use these and make this diagnosis easier. So this brings me to what we did. So we conducted a prospective observational study in 2015 and 16, over 2 years in 2 studies. We recruited neonates eligible for therapeutic hypothermia who were absent of other confounders at 2 sites. And we had 3 aims. First was to evaluate the changes in RV performance over time among neonates with HIE undergoing therapeutic hypothermia. The second was to interrogate the relationship between RV dysfunction and short-term outcomes, such as death or abnormal brain MRI, and long-term outcomes, including abnormal development at 18 months. And then finally, we had an exploratory aim to try to understand whether abnormal cerebral hemodynamics identified in the literature were more related to supply or more related to demand, and recognizing that it could be a combination of both. So this was our study protocol. The decision to initiate therapeutic hypothermia was entirely based on the clinical team. And then we performed blinded echocardiography at 24 hours, 72 hours, and 96 hours after rewarming. All the babies got standardized neurologic exams at various time points, an MRI on day 5, an MRI on day 4 to 5, and then neurodevelopmental follow-up at 18 months. This is our echo protocol, and a subsample of it. You can just look at it to kind of know that what we looked at was complex and included both LV performance and RV performance, as well as systemic hemodynamics. We particularly focused on measures of RV, and the ones that I'll just highlight briefly because they came out to be useful were the tricuspid annulus peak systolic excursion, so the movement of the tricuspid valve from apex to base with contraction, the RV fractional area change, which is a surrogate for RV ejection fraction, and then peak longitudinal strain, which we looked at in the RV3 chamber primarily. So what did we find? So this is addressing AIM-1. RV measurements were lowest at 24 hours in both groups, and all normalized by 96 hours. Some of the LV measures were also lower at 24 hours, but the lowest values, which were at 24 hours, were still within the normal range for LV function. Whereas the RV measures, especially in the adverse outcome group, were well below 2 standard deviations below the mean. And so we hypothesized that because the RV measures were substantially lower in the adverse outcome group, that the RV was the primary site of dysfunction, and the LV measures were abnormal either to a more minor degree of injury, going back to the fact that the RV is more vulnerable, or due to ventricular-ventricular interaction in the setting of shared muscle fibers. For our second aim, we looked at the two most strongly associated, or the two most strongly abnormal factors at 24 hours. And we used, we generated a receiver operating characteristic curve for those to predict the outcome of death or abnormal MRI consistent with HIE. And we found that both TAPSE less than 6 and RV fractional area change less than 0.29 had a relatively robust sensitivity and specificity, and had very good correlation with outcome with area under the curves between 0.83 and 0.88. And this was even, this effect was identified even after adjustment for illness severity and the severity of SARNAT encephalopathy at presentation. The graphs on the right show a box graph just comparing TAPSE, RV fractional area change, and cerebral RSO2 between normal and adverse outcome groups, showing a significant difference at 24 hours, whereas the LV ejection fraction was the same in both groups. So we then went on to use TAPSE to look at how good was this 24-hour echo at predicting long-term outcomes. And for adverse outcomes here, we used a composite diagnosis of cerebral palsy, any Bailey 3 less than 2 standard deviations below the mean, or severe neurosensory impairment, which were basically blindness and deafness with a standard definition. And here we found that TAPSE actually had an even higher area under the curve for predicting adverse neurodevelopmental outcome among survivors of 0.9. And we generated a predicted probabilities curve, which suggested that if your TAPSE is still 4 or less at 24 hours of age, your likelihood of adverse outcome in the long term was very high. And so this is not to say that we necessarily know whether we can use this information to make outcomes better, but certainly it suggests that that early echo can be a good prognostic tool. So when we were looking at aim number 3, we did a comparison of cerebral and systemic hemodynamics, looking at the relationship between left ventricular output and cerebral regional oxygen extraction. And what we found was that the RSO2 among patients with adverse outcome was high, despite low left ventricular output. So that suggests that at least a good proportion of the problem is a problem at the organ level with extraction, and not necessarily an issue as suggested by the earlier Doppler studies of excess flow being given to the brain. To further investigate this, we performed linear regression between both the middle cerebral artery resistive index and left ventricular output with cerebral tissue oxygen extraction. And we found on the left, you can see that the ability of MCA resistive index, which is a marker of perfusion pressure, to detect or to predict cerebral RSO2 was very poor, with an R squared value of 0.066. Similarly, not only is the ability of the LVO to predict oxygen extraction poor, but it actually goes in the opposite direction, which agrees with the previous data presented on our previous slide, that high cerebral tissue oxygen extraction is actually more likely to be a function, at least in good proportion, of oxygen extraction rather than exclusively a problem with blood flow. So then it's important to understand, when you're studying this patient population, whether therapeutic hypothermia itself actually modifies RV function. And this is important because, as we talked about, cooling increases pulmonary vascular resistance, and pulmonary vascular resistance is afterload, and afterload is coupled to RV function in the stress velocity relationship. So as your afterload increases, so too your contractility declines. And so this in this patient group, we took 10 patients who we scanned before cooling and then within an hour after achieving therapeutic hypothermia. And there were no changes in cardiovascular support over this hour interval. And so this is purely reflective of the reduction in temperature from normal to 33.5. And we looked at markers of pulmonary vascular resistance and pulmonary artery pressure. We also looked at RV function, and we looked at cardiac output. And what you can see is that systolic eccentricity index, or a measure of septal roundness, increased, so suggesting an increase in pulmonary artery pressure. And two measures, PVR index and notching of the pulmonary artery Doppler, deteriorated, suggesting higher pulmonary vascular resistance, which is in keeping with what we know from other data. And also, you can see that right and left ventricular output declined, which is also in keeping with the literature. But across the measures of RV function, there was actually no significant change, suggesting that either the coupling was not sufficient to result in a decline, so too minor a change to be detected, or other factors which were impacting on RV function were dominant, and that cooling itself was not significant enough to result in a change in RV performance. So in this small study, at least, we've shown that. So then the big question, is this a difference, or is this like a prognostic difference, or is this something that we can use to modify outcomes? And I don't think that we know that yet, but there are some suggestions that there are things that we can do that make outcomes worse. And so maybe that means that we can also make outcomes better. So I'll talk a little bit about dopamine first. So dopamine is by far in North America the first line agent used for low blood pressure across indications, across populations, and in this particular population specifically, in both normoxic and hypoxic patients. We know that dopamine increases blood pressure in asphyxiated newborns. But treatment with dopamine has actually been associated with an increased risk of the composite of death or abnormal MRI in one recent study in Frontiers of Pediatrics. And it just begs the question, why might that be? So whether this is cause or effect is unknown, but really considering the merits of dopamine, I think, is important. So we conducted this study. This is a retrospective cohort of 176 term patients in 2 centers. Center A featured a permissive approach to hypotension, which was focused on the use of systolic and diastolic blood pressure and used the 3rd percentile. with TN echo guided care as often as possible, and the inotrope-focused, an inotrope-focused approach to therapy using dobutamine as a first line and rescue low-dose epinephrine. Center B featured a more aggressive approach in which the mean blood pressure less than gestational age was always treated with a vasopressor-focused strategy, which amounted basically always to dopamine. And the echocardiography was performed more infrequently. What we found was that nearly half the patients in Center A were untreated versus only 3% in Center B, despite a similar lowest recorded blood pressure. And also hypertension was much more frequent in Center B. And then looking at the degree of brain injury in this patient population, although the rates of death or abnormal MRI were similar, the pattern of brain injury itself was actually different. Despite less hypotension, Center B patients were more likely to have basal ganglia injury. And this suggests a more sustained or more severe exposure to injury. In contrast, the patients in the less aggressive inotrope-focused center were more likely to have milder phenotypes. And that was reflected by a threefold increase in focal multifocal lesions, which are generally associated with good outcome, and a fourfold increase in watershed injury. And so this is hypothesis generating that perhaps ischemia reperfusion injury and hypertension are potential contributors to adverse outcome. The other thing that we know is that babies' blood pressure at 24 hours does not necessarily predict their degree of abnormality on echo. And this is a cohort of babies who had blinded echocardiography. Some were treated, some were untreated. And then we looked at their echoes. And you can see there that their TAPSE in the inotrope treated group was only 5.8 despite normal blood pressure. And even in the control group, a TAPSE of 7 is in the mild dysfunction range. For 24 hours for a term patient. And within that control group, there were still quite a number of babies who had TAPSEs consistent with at least moderate dysfunction. So then kind of thinking about the effects of dopamine in the pulmonary vascular bed, which we've kind of already talked about as a potential problem in these babies. This is a study done in an animal model, a large animal model, where asphyxiated piglets were given either high-dose dopamine at 20 mics per kilo per minute or dopamine plus epi at 10 mics plus or 0.2 mics per kilo per minute. And what they showed is that there was a pretty substantial increase in the ratio of pulmonary artery pressure to mean arterial pressure in both situations. And when we kind of go back to what patients we're talking about here, this is probably not something that we really want. And we should be thinking about therapeutic strategies that are positive inotropic, because we know that there's heart dysfunction, and not pulmonary vasoconstrictors. And there are some drugs that are biologically like that, but we don't have a lot of scientific data to back them up yet. And this is just a reminder. So I mentioned the stress velocity relationship previously. On the left, you have rate corrected VCF, which is a surrogate for contractility on the y-axis, and on the x-axis you have end systolic wall stretch, which is a surrogate for afterload. And you can see that there's a pretty steep decline in contractility associated with small increases in afterload in the neonatal population as compared to the adult, which is the graph on the bottom. And the graph on the right is a comparison of the LV in the open circles with the RV in the dark circles, showing that the RV in particular adapts very poorly to increases in afterload. And so for patients with a high risk of pre-existing RV dysfunction and also high mean pulmonary artery pressure, added afterload from exogenous vasopressors like dopamine or high-dose epinephrine might actually exacerbate RV dysfunction and precipitate clinical decompensation. And it may actually look like the babies are just getting worse because the disease is getting worse, but actually sometimes this is actually iatrogenic, that they decompensate. So thinking about other alternative strategies, we have a whole bunch of other things at our disposal, and these are common ones used in North America. You guys might use something different, phenylephrine or other things there. But our most common vasopressors are vasopressin and norepinephrine. Our most common inotropes are dobutamine and milrinone. And although several biologically logical options such as vasopressin exist, there's very little data that's specific to the HIE therapeutic hypothermia population. And I'll just show you why that's important. So taking milrinone as an example, milrinone is a very good drug for the treatment of hypoxemic respiratory failure. It has efficacy in reducing oxygenation index and FiO2. It's associated with increased cardiac output as manifested by increased urine output, increased pH, and also by decreased INO requirement, reflecting higher pulmonary blood flow. It has been documented to improve LV and RV function in term babies in a variety of diseases. And so it's logical as an agent to think about using in these babies when we know that they have concurrent pulmonary hypertension. So this is a study that we conducted and published just recently. And this is a cohort of patients who had acute pulmonary hypertension with refractory oxygenation failure despite treatment with inhaled nitric oxide. So despite being on 20 parts of nitric oxide, these babies were in at least 60% oxygen. The patients in purple had milrinone added as an adjuvant therapy. The patients in green also had concurrent hypoxemic encephalopathy and were treated with therapeutic hypothermia. And the patients in in red, both were being cooled and were treated with milrinone. And you can see from the two graphs of blood pressure on the left and in the middle that there was a pretty stark drop in blood pressure in the red circles as compared to the purple or the green. And this was associated with a very dramatic increase in modified inotrope score, and it was modified just to exclude milrinone, reflecting a very substantial escalation in vasoactive medications following milrinone exposure, despite the fact that many of these babies actually had the milrinone discontinued within a couple of hours because of severe hypotension. So this is biologically logical that milrinone would cause dramatic hypotension in this patient population because milrinone is cleared by the kidney with very little metabolism. And so if patients have acute kidney injury and also are not making a lot of urine because of cooling, this medication will just circulate around in the system until eventually it gets gradually excreted. But in the meantime, because it's a systemic vasodilator, you get a pretty substantial response in low blood pressure. And we could correct the blood pressure. All these blood pressures did gradually come up, but at a cost of a significant increase in medication, which results in a lot of fluctuation of blood pressure, therefore a lot of fluctuation in flow to the brain. And that probably isn't a good thing in this patient population. So with that, I'm just going to wrap up and I can take some questions, but my take-home points are that cardiovascular health is a really important consideration in this patient population, and it may actually end up being a way that we can improve outcomes. But we really need to make sure that we're comprehensively monitoring these babies and that we're starting to work on agreeing on what constitutes abnormal. We know that cardiac dysfunction is common. The RV is particularly vulnerable, and so echocardiography is really important, and particularly objective measures of RV function should be something that people are considering in their regular practice so that we get a better understanding of how that changes with disease. We really, really need to understand pharmacotherapy better, and we have to be very careful to not extrapolate directly from other populations because hypoxia ischemia and therapeutic hypothermia are very abnormal states for babies, and they both have a lot of implications on how behavior how medications behave. And so having an idea of the pharmacotherapy is really crucial in order for us to avoid unintended consequences of medications that we are giving to try and be helpful. And with that, I'd just like to thank the Iowa Neonatal Hemodynamics Lab. These are my 4 colleagues who have contributed a lot of ideas and echoes to my work, and also our collaborators around the world who have also contributed to some of those studies that I mentioned. Thank you very much.
Well, thank you very much, Dr. Geisinger, for your excellent and very interesting presentations. I think it has widened our horizon on this subject about the relationship between the cardiac and the HIE. Next, I would like to introduce Dr. Johannes Edi Siswanto, who will be the panelist this evening. Let me read his curriculum vitae first. So Dr. Johannes Edi Siswanto, SPAK, is a neonatology working group in position as kita. He is a clinical education doctor of Ministry of Health and Indonesia. He is a adjunct lecturer, Family of Medicine, University of Indonesia. He's a TOT of Ministry of Health Indonesia, HSP US8 program since 2005, and TOT for NRP, Neonatal Resuscitation Program, Trinasia since 2012, TOT for Neonate Stabilization, and TOT for Neonatal Resuscitation IPA program since 2017. He's a medical doctor from Faculty of Indonesia, University of Indonesia, pediatrician from Diponegoro University, and fellow of neonatology of UMC Groningen, Netherlands, 2003, and pediatric consultant in neonatology, 2008, and doctors in clinical epidemiology, Faculty of Public Health, and PhD at University of Groningen in July 2021. Okay, welcome, Dr. Johannes Edi.
Okay, thank you for the moderator, Professor Najib Advani, for the nice introduction for me. And that I think the others, thank you for you give us the time for provide comment and suggestion for Dr. Regan's presentation. I also salute and appreciate to our guest lecturer, Dr. Regan Geisinger, who gave insight into the importance of the echocardiography evaluation for outcome assessment of brain injury in hypoxic ischemic encephalopathy. And then thank you for reminding us about dopamine that we use sometimes in the problem of the pulmonary problem in sometimes although the baby in the therapeutic hypothermia. About the dangers of dopamine to keep minimal and I think brain injury that you said in your a few of slides in your presentations. According to Professor Najib, this topic is rather new for us. It's not only new. I think it's rather difficult. I don't know about the cardiologist for evaluation of the right ventricle correlation with the problem of the neurodevelopmental outcome in the patient with the therapeutic of hypothermia. But in our opinion, when we talk about the RV assessment, we are talk about the intra to extrauterine adaptation. Yeah. The second, we talk about the physiology of pulmonary vascular dysregulation and right ventricular dysfunction. About the physiology and pulmonary vascular dysregulation and dysfunction, ventricular right dysfunction, many factors I think affect the change of the dominance of circulation in the right heart area in the first time in the uterine, and then changes suddenly to the dominance of blood circulation in the left heart area after the baby deliver. And then this is change the pulmonary vascular in the baby. I think the problem, especially in Indonesia, there is a problem. There are many sepsis condition change for everything in our condition in the neonatology department. Yeah, pulmonary vascular disease leads to the heart rate, to high right ventricular afterload, and then this is because the right ventricle in this condition is particularly vulnerable. And then after that, the problem is about low cardiac output that cause further right ventricular dysfunction due to the impaired coronary perfusion and adverse ventricular interaction. And then, yeah, we know about there are many problems about HIE in Indonesia, hypoxic ischemic of encephalopathy. There are many questions that must be explored about the connection between this topic. I think, yeah, about how about the different cerebral blood flow product make different outcomes, and then the extent to which the role of the hypoperfusion that you try to give explanation in your presentation about the cause problem in the outcome of the baby. Also for us, it is very complicated and complex to imagine that the change of the condition about the baby in the occurrence of the hypothermia therapy and then during rewarming. I think it's very complicated. Yeah. How about the condition is very changed in this two conditions, yeah, between hypothermia, after that rewarming in the patient with asphyxia. And then we know maybe how the important is the role of the NIRS, yeah, near infrared spectroscopy in assessing the ratio of the oxygenation in the brain or in the somatic area. Yeah, the first question from me as an analyst, indeed, we have already known that the oxygen is closely related to the brain outcomes. And in our country, there are many incidents of asphyxia, yeah, especially in the countryside. Yeah. In the center, I think the condition of asphyxia is not rather low, yeah. But in the countryside, the asphyxia is the problem. It is one of the cause of the neonatal deaths in Indonesia beside sepsis and low birth weight baby. Is there any special suggestion from you as a neonatologist who may have a slightly different background from the knowledge and from the facilities that from Iowa, that to prevent a poor prognosis outcome in the incidence of hypoxic ischemic encephalopathy? And then how important is the completeness of the monitoring in performing hypothermic therapy to reduce the unexpected incidence of hypothermic therapy on the outcome of HIE. And then in your opinion, it is possible to treat hypothermia in a limited facility with the minimal monitoring facilities, especially since you give the idea that RV assessment is very important in evaluating the outcome of hypoxic ischemic encephalopathy. This is the first question. And then the second question about the role of the pediatric cardiologist and neonatologist. Yeah. What is the role of the echocardiography in the first 3 days when the patient is exposed to moderate and severe HIE and should be treated for hypothermia? When did we do it the first time that we must consult to the cardiology department for echocardiography? Because you know that therapy hypothermia is as soon as possible in the first until the 3rd day. As soon as possible, we must consult the cardiology to evaluate the RV assessment or not. And then how often do cardiologists monitor about cardiovascular function in the RV area to confirm the abnormality? And we think that we should have the intervention after we found there is a problem about RV abnormality. And then how about the role of the neonatologist to perform initial echocardiographic examination while on site in the unit? Although that in your unit, that as a neonatologist, that you did learn about evaluation of the echocardiography problem. And then, yeah, this is the second question about the role of the pediatric cardiologist and the neonatologist. And then the third question, as far as the Dr. Jan's experience from you in evaluating the right ventricle with echocardiography, what are the important points that must be considered which distinguish between RV assessment in normothermic and hypothermic condition? Is it very different or no? Yeah, in normothermic or hypothermic condition, which states that hypothermic therapy is very useful in the condition with asphyxia. Yeah, sometimes in Indonesia we suggest as soon as possible therapy hypothermia for the baby, but there are different level of the service level of perinatology in Indonesia. One is in the complicated and the complete facilities, the other in the limited facilities. Maybe you have a comment about that. About
sure. So,
point, yeah.
So to kind of just wrap up your questions. So I think that in low resource settings, it's really important that temperature be maintained within the normal range. If cooling is going to be done, it's very important that babies don't get too cold. If cooling is not feasible, it's very important that babies don't get too hot. And one of the ways to make sure that outcome is as optimal as possible in a low resource setting is to have mechanisms in place to do that and minimize fluctuation in temperature. I think that it's pretty hard in a low resource setting to operationalize regular echocardiography without access to more sophisticated intensive care and that type of thing. When you move the setting into a more advanced practice where there's access to pediatric cardiology or other people who are trained in echo, the type of patients to very highly prioritize for relatively early echo are ones who have multi-organ dysfunction, ones that are ventilated, and ones with on the more kind of at least moderate or moderate to severe spectrum, because that's where your highest yield is for finding cardiac dysfunction. The mildly asphyxiated patients who are on room air, not ventilated with CPAP or something, I think you can kind of leave those ones for a secondary tier. In terms of when an echo should be done, I would say relatively early in the course. Between kind of 6 and 12 hours is nice. Before 24 hours is ideal. Because the longer you leave subclinical heart dysfunction, theoretically, the more likely you are to be having an adverse impact on the baby. And people in the chat have been asking some questions about approach to therapy. I think that our approach is to use Dobutamine as a first line therapy because it's a good positive inotrope that is not going to impact negatively on PVR. And it's also not going to negatively impact on SVR. And if Dobutamine is not effective, then we would use low dose epinephrine in the dosing range of 0.03 to 0.08 mics per kilo per minute for its positive inotropic effect. Epinephrine is a pulmonary vasoconstrictor, but if you keep the dose low, you're less likely to have problems with that. And in terms of who does the scans, I think that that's really individualized across practices. In our practice, neonatologists perform the scans for these babies, but we have a very good working relationship with cardiology and frequently refer to them for things that we may find on those echoes. In other practices, cardiologists are doing those scans. And I think as long as people are looking at things comprehensively, it doesn't really matter who does them. What I would like to just keep people abreast of is that qualitative assessment is not enough. And someone put in the chat some examples of things like tissue Doppler and myocardial performance index. I would advocate for TAPSE to be added to most protocols. It's really easy to do. And there's the most normative data for it, as well as it being associated with adverse outcomes in both the HIE population, as well as the pulmonary hypertension population risk of death or ECMO with a TAPSE less than 6. So I think that if you're going to add one objective measure, that's the objective measure to add. And in terms of when to follow up, I think that depends on your initial echo. I would suggest that if you have an abnormal echo and you put a baby on therapy, that you probably follow up within about 24 hours to make sure that things have resolved. But it can be sooner if the baby is sick. So we sometimes will see these babies a couple of times a day just to make sure that their heart is better. Sometimes they need prostaglandin to open up their ductus, in which case we would see them before and after that. But in the straightforward patient who just has isolated RV dysfunction with either a closed or left to right ductus, you can probably leave them for about 24 hours.
Okay, thank you, Dr. Regan, for your information and your question, your answer. But how many unit in your in Iowa? This is the RV assessment makes the to be the protocol in all of the units about evaluation about asphyxia and in therapy hypothermia.
So all of them, but there's only the way that our state is set up. There are 3 tertiary centers, and then our center, which is the quaternary center, so a referral center. Patients who are complex with HIE get referred to us. And so we do the majority of that cooling, but all the tertiary centers are doing echocardiography.
Okay. Yeah, but for me, it's very strange that in Iowa, there are many patients with the asphyxia condition. Yeah. And then the last question maybe from me, and maybe I ask permit from Prof. Najib about we know about the preterm conditions. Preterm infants are more tolerate with acidosis and hypoxic conditions. Yeah. Is there any difference with the RV assessment regarding the outcome of the SIE in the condition of premature infant who are asphyxiated and allow for hypothermic therapy? Yeah, between 1800 until 2500 with the term infant who have asphyxia. Is there any difference in RV assessment?
So our cohort actually included those patients because we cool babies greater than 1800 grams. And I didn't find any difference. The only potential difference is that the normative data for smaller babies is to allow them to have a little bit lower, for example, TAPSE. And so for that, we had to use TAPSE Z-scored to gestational age, and we found a similar pattern. Preterm infants that are extremely preterm also have RV dysfunction when they've been asphyxiated. We just don't talk about it that much, and we don't talk about asphyxia in extremely preterm infants very much either, because we don't really have a way to do anything about it. But it's still the same physiology occurs, and we see it quite often in our extremely preterm babies too. So something to think about. And there is some normative data, particularly for TAPSE in the small babies.
Thank you, Dr. Regan. Maybe this is the new idea for us. Yeah, maybe this is a chance for Dr. Winda and Dr. Sarif and the other colleague from cardiology that we can examine of the RV assessment when we have a problem about asphyxia in our unit, because sometimes we have there is a referral patient from the other area. We hope that we can achieve that patient in the 6 hours of birth. Yeah, I think maybe we can coordinate with the cardiology department in our hospital. Yeah, how to manage the baby. Yeah, and thank you for remind us about dopamine in our topic in these conditions. Thank you, Dr. Regan, and then I give back to the time to Professor Najib for the other discussion.
Well, thank you, Dr. Edijo, for your nice, interesting comments on this subject. Yeah, I think with you that we have to move forward. Yeah, I mean that we have to examine RV function as early as possible in babies with some problems like this. Yeah, which is now we don't do it routinely, so we have to start doing after listening to the research of Dr. Geisinger. Okay, I think there may be some questions. Any questions? So I read some questions for. Okay. Well, there's some questions. The first is from Dr. Winda to Dr. Geisinger. How about dopamine instead of milrinone to treat HIE? And the second is how to determine RV dysfunction in neonates with single ventricle.
Yeah, so I completely agree with dobutamine. I think that that's a very good starting point. As to the congenital heart disease population, that's a lot more difficult. And I think the normative data just kind of doesn't necessarily exist. If you have something simple like a VSD or an AVSD, maybe you can use term normative data, but I don't think that that applies to a single ventricle. And so I think we would have to think more about things like strain and those other types of modalities. And I'm not aware of whether people have done that work yet.
Okay, the next is from Dr. I.D. Budi. Thank you for the great presentation. In the limited facilities without echo function of RV, what is the best option if we suspect there is a cardiac dysfunction or HIA? Dobutamine, milrinone, all of those epinephrine plus milrinone.
I think it depends on how sick the baby is, whether you go with dobutamine as a first-line therapy or low-dose epinephrine on its own as a first-line therapy. Either would be fine. I think if you are not getting what you want in terms of clinical response from dobutamine at 10, then dobutamine is not likely to be an agent that's going to fix the problem for you. And then I would suggest that you switch to epinephrine at a dose of somewhere in the neighborhood of 0.05 as a starting dose.
Okay, the next question is from Dr. Ahmad Kausar. Thank you, Dr. Geisinger, for the lecture. My questions are the following. The first is, in cooled babies with uncontrolled pulmonary hypertension, what is your approach in terms of therapeutic hypotension? Do you stop cooling or increase your target temperature? And the second is, what is your suggestion to treat PPHN in this baby in low resource setting?
So in cooled babies, I think it depends on how sick. So we always try to maintain the cooling if we can, despite pulmonary hypertension. But if the consequence of the cooling is that the baby has multiple episodes of arrest or saturations that are not coming up out of the 70s, then those are babies who might benefit less from the cooling because they're having ongoing supply to their brain issues. And so we would typically try to do all the medical management possible first. So optimize heart function, open the duct if necessary, optimize blood pressure with pulmonary vascular bed friendly agents like vasopressin, reduce pulmonary vascular resistance with whatever we have available, whether that's nitric oxide or sildenafil. And if those things are not effective at establishing pulmonary blood flow, then we might increase the target temperature by a degree to start and see if that makes it better, another degree and see if that makes it better, and try to preserve some of the benefits of cooling as possible. I think that if you wait until a baby is optimized from a pulmonary vascular bed before instituting therapeutic hypothermia. So for example, the very sick meconium aspiration baby or hypoxic respiratory failure baby who has also got HIE, but is in your delivery room with poor sats and not in a good shape. I would advocate treating those babies and getting them stabilized and out of 100% oxygen first before instituting therapeutic hypothermia, because you're more likely to be successful that way. In terms of in a low risk setting, I think sildenafil is a reasonable option. It hasn't been studied that much, but there is some data to suggest that sildenafil also has some neuroprotective benefits. And an individual in Canada who's currently doing some pretty extensive research on that and has published some benefits. So I would think that that would be a good alternative agent for pulmonary vascular disease, and then optimizing heart function with dobutamine or epinephrine.
Yes, the next question is, the best evidence we had so far in LMIC for cooling in associated units is Helix trial, which does not show a significant improvement. Do you think one of the main reasons is the lack of cardiac assessment? Can we rely on qualitative measurement, for example, flattening ventricular septum on eyeballing, or serial measurement of non-invasive blood pressure?
The LMIC trial that was done, the Helix trial, I think that there's probably a lot of reasons why that didn't show difference. There is a huge heterogeneity in how babies can present with HIE. And it's hard in particularly low income scenarios to really define population well and to get a really good idea of what babies' a priori risk of poor outcome is. There's also a lot of inconsistency in how places were able to institute the cooling and how effective it was and what was available to those. But I do think that not having the ability to discern what the secondary causes of injury, one of which is heart function, has a role to play in not accurately delineating the population that you're trying to study. And I think that subjective measurements, if that's all you have, are all you have, and you have to rely on them. But particularly for mild or mild to moderate disease, they're poorly sensitive. And so using something like eccentricity index, where you measure the degree of LV circularity directly, it's very easy. You just measure the cross-sectional versus the parallel to the septum distance and divide them by each other. You end up with more reliable information, and you can actually follow it from echo to echo, meaning that you'll get longitudinal data in a particular patient also.
Okay, the next question is from Dr. Sharif. He is a pediatric cardiologist. In daily practice, measurement of RV function is not routinely done, since less information can be assessed with 2D, such as RV dysfunction. So we do tissue Doppler imaging of RV in order to have both the diastolic and systolic RV myocardial dysfunction, also RV MPI. How is your opinion about this?
I think that's great. I think the only thing I would add, as I mentioned, is TAPSE to that. But there is data that can be used as normative data for that. There were publications in 2014 and 2015. The last author is Jane, Jain, or the first author, sorry, is Jane. And those having more information, more comprehensive information and more objective information can only help you in following these babies.
Okay, next question from Dr. Suparhaita. She's a pediatric cardiologist also. Thank you, Dr. Geisinger. There is TAPSI value standard for neonates. Is there any TAPSI standard for neonates? This is important to evaluate neonates with RDS. Maybe this can be a research project in our NICU.
So there is data in term infants, and that is the first author is Jane, Jain. The preterm data is relatively less well fleshed out. There is one publication by, I think the last name's Kostenberg, that they've looked at some values in TAPSI in preterm infants, but that space is still relatively open for research, looking at normative data in preterm infants.
And the last question is from Dr. Vinda, she's a pediatric cardiologist also. Could we use head ultrasound instead of brain MRI to access cerebral blood flow? And the second is, how about the role of beta blockers to reverse remodeling in myocardial injury for neonatal populations?
So head ultrasound and Doppler of brain blood flow can be used. It doesn't necessarily give you the value for cerebral blood flow, but you can get an idea of that from middle cerebral artery. Resistive index gives you perfusion pressure, and it'll give you velocity of blood flow. There are some devices that are coming out in the neonatal population that can measure cerebral blood flow using the movement of RBCs, but that stuff is kind of relatively early yet. And some NIRS monitors are able to give you cerebral blood flow, which they use a volumetric measurement also. So if you have an ultrasound, it's pretty easy to measure the MCA Doppler. It's at the temporal fossa, looking at the eye with the marker pointing towards the eye, and you'll see a straight red blood vessel in there to Doppler.
Okay, there's another last question is from Dr. ID. Do you routinely measure EA ratio for diastolic dysfunction?
Yep, we do. And we also measure E to E prime. As a kind of relatively less volume dependent measure of diastolic function. The normative data for E prime is kind of not well established, but we do use it as a trending tool. I haven't particularly noticed that there is a significant problem with diastolic dysfunction in particularly for the LV in HI patients, but that's an area that could be studied.
Well, thank you. Due to time restriction, we have to end the session here. I would like to thank a lot for Dr. Geisinger and Dr. Edijo also for your valuable contribution in this program. Yeah. Okay, we go back to Dr. Rinda. Thanks a lot. Also, thanks to all the audience for joining.
Thank you very much.
Thank you. Thank you very much, Prof. Najib, and also to Dr. Geisinger. We're really happy to have you with us this evening in Jakarta and morning in Iowa. We have a pediatric cardiologist and also neonatologist, but we still, we do not start the targeted neonatal echo in our country. Do you have any suggestion to start that program? Okay, I think we have to close this event. Thank you so much for all participants, professors, seniors, and colleagues. We hope this event have a more benefit to your practice, and we can start the neonatal hemodynamic and cardiovascular assessment in the future. On behalf of our hospital, we would like to say thanks and goodbye, and see you again in our next guest lecture. Before that, I think we can have a photo session. Please, the committee to take a photo shot. Okay, everybody, please let your camera on. Ready? One. Smile.
Okay. Okay, dong.
Okay. All right. Thank you so much, everyone. It's already getting late. See you again in our guest lecture. Goodbye.
Bye. Thank you.
Prof. Najib. Thank you, Pak Didi.
Yeah, and everybody. Thank you.
Yeah.
Thank you, Profesor Najib, Dr.
Thank
Winda, Dr. Edijo, Dr. Sarip, Dr. Supareta.
Thank you, harapan kita.
Ya, bye.
Terima kasih Prof. Najib.
Prof. Najib.
Bye.
Indah, semua.
Yo.
Terima kasih.
Perempuan Indonesia tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit harapan kita, pusat kesehatan anak dan bunda. Wahai perempuan Indonesia, tercipta sebagai ibu bangsa, melahirkan insan yang mulia, sehat dalam jiwa dan raga. Kami terdepan dalam tugas untuk melayani kesehatan Anda, melindungi sang buah hati agar sehat senantiasa selamanya. Rumah sakit anak dan bunda, harapan kita melayani sepenuh hati ibu dan anak negeri. Rumah sakit anak dan bunda, harapan kita sehatkan Indonesia.